The objectives for this lecture are as follows. Discuss the anatomy of the airway and the physiology of breathing. Identify the components of airway and respiratory system assessment. Discuss airway management for the routine and difficult airway. Describe the proper evaluation of the airway. Airway management is an essential skill for any anesthesia provider. Other than rendering a patient insensible to pain, no characteristic better defines what we do than to manage an airway and our patient's breathing. Successful manipulation, intubation, and ventilation requires detailed knowledge of airway anatomy. Now this is the not so glamorous part of the lecture, but basic knowledge is imperative. Let's start out with the easy stuff. The nose and the mouth lead to the oropharynx. They are separated anteriorly by the palate, but they join posteriorly in the pharynx. The pharynx is a U-shaped fibromuscular structure that extends from the base of the skull to the cricoid cartilage at the entrance to the esophagus. The nasopharynx is separated from the oropharynx by an imaginary plane that extends posteriorly. At the base of the tongue, the epiglottis functionally separates the oropharynx from the laryngopharynx. The epiglottis prevents aspiration by covering the glottis, the opening to the larynx. The larynx is composed of 9 cartilages. There are 3 unpaired cartilages, thyroid, cricoid, and epiglottic, and 3 paired cartilages, arytenoids, corniculate, and cuneiform. The thyroid cartilage is the largest and most prominent, forming the anterior and lateral walls. The cricoid cartilage is shaped like a signet ring, faces posteriorly, and is the most complete cartilaginous ring of the laryngeotracheal tree. The cricothyroid membrane connects these structures anteriorly. The epiglottis extends superiorly into the hypopharynx and covers the entrance of the larynx during swallowing. The corniculate and cuneiform pairs of cartilages are relatively small and do not figure prominently into the laryngoscopic appearance of the larynx or its function. The arytenoid cartilages articulate upon the posterior aspects of the larynx and are the posterior attachments of the vocal cords. Identification of the arytenoid cartilages may be important during laryngoscopy. In a patient with an anterior airway, the arytenoids may be the only visible structures. Finally, the vocal cords attach anteriorly to the thyroid cartilage. The sensory supply to the upper airway is derived from the cranial nerves. The mucous membranes of the nose are innervated by the ophthalmic division of the trigeminal nerve anteriorly and by the maxillary division posteriorly. The palatine nerves provide sensory fibers from the trigeminal nerve to the superior and inferior surfaces of the hard and soft palate. The lingual nerve and the glossopharyngeal nerve provide general sensation to the anterior 2/3 and posterior 1/3 of the tongue. Branches of the facial nerve and glossopharyngeal nerve provide the sensation of taste to those areas. The glossopharyngeal nerve also innervates the roof of the pharynx, the tonsils, and the undersurface of the soft palate. The vagus nerve provides sensation to the airway below the epiglottis. The superior laryngeal branch of the vagus divides into an external motor nerve and an internal sensory laryngeal nerve that provides sensory supply to the larynx between the epiglottis and the vocal cords. Another branch of the vagus, the recurrent laryngeal nerve, innervates the larynx below the vocal cords and the trachea. The muscles of the larynx are innervated by the recurrent laryngeal nerve with the exception of the cricothyroid muscle, which is innervated by the external motor laryngeal nerve, a branch of the superior laryngeal nerve. The posterior cricoarytenoid muscles are the principal adductors. Phonation involves complex simultaneous actions by several laryngeal muscles. Damage to the motor nerves innervating the larynx leads to a spectrum of speech disorders. Unilateral denervation of a cricothyroid muscle causes very subtle clinical findings. Bilateral palsy of the superior laryngeal nerve may result in hoarseness or easy tiring of the voice, but airway control is not jeopardized. Unilateral paralysis of a recurrent laryngeal nerve results in paralysis of the ipsilateral vocal cord, causing a deterioration in vocal quality. Assuming the superior laryngeal nerve is intact, acute bilateral recurrent laryngeal nerve palsy can result in stridor and respiratory distress because of the remaining unopposed tension of the cricothyroid muscles. Airway problems are less frequent in chronic bilateral recurrent laryngeal nerve loss because of the development of various compensatory mechanisms. Bilateral injury to the vagus nerve affects both the superior and the recurrent laryngeal nerves. meaning bilateral vagal denervation produces flaccid, mid-position vocal cords similar to those seen after administration of succinylcholine. Although phonation is severely impaired in these patients, airway control is rarely a problem. The blood supply of the larynx is derived from branches of the thyroid arteries. The cricothyroid artery arises from the superior thyroid artery itself, the first branch given off from the external carotid artery, and crosses the upper cricothyroid membrane, which extends from the cricoid cartilages to the thyroid cartilage. The superior thyroid artery is found along the lateral edge of the cricothyroid membrane. When planning a cricothyrotomy, the anatomy of the cricothyroid artery and the thyroid artery should be considered. It is best to stay in the midline, midway between the cricoids and thyroid cartilages. Loss of the upper airway muscle tone in an anesthetized patient allows the tongue and epiglottis to fall back against the posterior wall of the pharynx. Before you start tearing open packages and shoving devices in orifices, try some simple repositioning. Repositioning the head or a jaw thrust is a preferred technique for opening the airway. To maintain the opening, though, an artificial airway can be inserted through the mouth or nose to create an air passage between the tongue and the posterior pharyngeal wall. The importance of these simple devices cannot be overstated because the tongue is the most frequent cause of airway obstruction, particularly in the unconscious patient. Nasal airways or trumpets can be gently inserted down the nasal passages into the nasopharynx. The length of a nasal airway can be estimated as the distance from the nares to the meatus of the ear, and should be approximately 2 to 4 centimeters longer than the oral airway. Because of the risk of epistaxis, nasal airways should not be used in anticoagulated patients, in children with prominent adenoids, or in any patient who has a basilar skull fracture. Although they look especially painful, nasal airways are usually better tolerated than oral airways in lightly anesthetized patients. In some cases, you can improvise and use a nasal airway for an oral airway, or in the case of this picture, 2 nasal airways. The use of a face mask can facilitate the delivery of oxygen or of an anesthetic gas from a breathing system to a patient by creating an airtight seal with the patient's face. The rim of the mask is contoured and conforms to a variety of facial features. Transparent masks allow observation of exhaled humidified gas and immediate recognition of vomiting. Black rubber masks are pliable enough to adapt to uncommon facial structures. Retaining hooks surrounding the orifice can be attached to a head strap so that the mask does not have to be continually held in place. Some pediatric masks are specially designed to minimize apparatus dead space. Effective ventilation requires both a gas-tight mask fit and a patent airway. How many times have you responded to a code and heard the face farts from the elevator doors from whoever had grabbed the ambu bag so they could get the stomach nice and distended for you? Improper face mask technique can result in continued deflation of the anesthesia reservoir bag when the adjustable pressure limiting valve is closed, usually indicating a substantial leak around the mask. In difficult situations, 2 hands may be needed to provide adequate jaw thrust and create a mask seal. It is often difficult to form an adequate mask fit with the cheeks of edentulous patients. Leaving dentures in place, which literature does not necessarily recommend, or packing the buccal cavities with gauze may help. Positive pressure ventilation should normally be limited to 20 centimeters of water to avoid stomach inflation. Mask ventilation for long periods may result in pressure injury to branches of the trigeminal or facial nerves. If the face mask and mask straps are used for extended periods, the position should be regularly changed to prevent injury. Care should be used to avoid pressure on the eye, and the eye should be taped shut to minimize the risk of a corneal abrasion. The laryngeal mask airway is being increasingly used in place of a face mask or endotracheal tube during administration of an anesthetic to facilitate ventilation or to pass an endotracheal tube in a patient with a difficult airway. The LMA has surpassed the combi tube as a preferred device to manage a difficult airway. The 4 most common types of LMAs used are the reusable LMA, an improved disposable LMA, the ProSeal LMA, and the Fast Track LMA. The original LMAs were designed for use up to 40 times. Protein contamination occurs after the first use and increases with each subsequent use despite proper cleaning and autoclaving. Disposable LMAs have been developed to prevent cross-infection. The ProSeal LMA has an orifice through which a nasogastric tube can be inserted and that facilitates positive pressure ventilation with higher airway pressures than with traditional LMAs. A second posterior cuff and deeper bowl were designed to improve the seal around the larynx. It also includes a reinforced airway tube that is narrower than that of the traditional LMA and an integrated bite block. The Fast Track LMA facilitates intubating patients with difficult airways. The reusable LMA, which is autoclavable, is made of silicone rubber, which is latex-free and is available in many sizes. An LMA consists of a wide-bore tube whose proximal end connects to a breathing circuit with a standard 15 mm connector, and whose distal end is attached to an elliptical cuff that can be inflated through a pilot tube. The deflated cuff is lubricated and inserted blindly into the hypopharynx so that once inflated, the cuff forms a low-pressure seal around the entrance to the larynx. This requires an anesthetic depth slightly greater than required for the insertion of an oral airway. Anatomic variations prevent adequate functioning in some patients. I'm not sure if the gentleman in this picture is sporting a halo or has just been impaled by something, but you get the idea. Partial cuff inflation prior to insertion may be helpful. Contraindications for the LMA include patients with pharyngeal pathology, pharyngeal obstruction, full stomachs, or low pulmonary compliance requiring peak inspiratory pressures greater than 30 centimeters of water. Traditionally, the LMA has been avoided in patients with bronchospasm or high airway resistance, but new evidence suggests that because it is not placed in the trachea, the use of an LMA is associated with less bronchospasm than an endotracheal tube. Endotracheal tubes can be used to deliver anesthetic gases directly into the trachea and allow the most control of ventilation and oxygenation. ET standards govern tube manufacturing, and most are commonly made from polyvinyl chloride. The patient end of the tube is beveled to aid visualization and insertion through the vocal cords. Most of the tubes used in the operating room have a hole referred to as the Murphy's eye to decrease the risk of occlusion. Most adult ET tubes have a cuff inflation system consisting of a valve, pilot balloon, inflating tube, and cuff. The valve prevents air loss after cuff inflation. Cuff pressures depend on the inflation volume, the diameter of the cuff in relation to the trachea, tracheal and cuff compliance, and intrathoracic pressure. Cuff pressure may rise during general anesthesia as a result of the diffusion of nitrous oxide from the tracheal mucosa into the cuff. Resistance to airflow depends primarily on tube diameter, but is also affected by tube length and curvature. The endotracheal tube is usually designated in millimeters of internal diameter, and its size is always a compromise between maximizing flow with a large size and minimizing airway trauma with a small size. Endotracheal tubes have been modified for a variety of specialized applications. Flexible, spiral-wound, wire-reinforced endotracheal tubes resist kinking and may prove valuable in some head and neck surgical procedures or in the prone patient. If an armored tube becomes kinked from extreme pressure, however, the lumen will tend to remain occluded and the tube will need to be replaced. Other specialized tubes include microlaryngeal tubes, ray preformed tubes, and double lumen endotracheal tubes. Microlaryngeal tubes, or MLT tubes, are commonly used during endoscopy. Most commonly, patients in endoscopy are intubated with a small diameter, like a 4.0 or 6.0 tracheal tube. A 4.0, 5.0, or 6.0 MLT tube is the same length of an adult tube, has a disproportionately large high-volume, low-pressure cuff, and is stiffer and less prone to compression than a regular tracheal tube. Double lumen tubes are often used for thoracic surgeries, and their placement is performed to achieve lung separation. The double lumen tube is placed in the trachea with one lumen in either the left or right bronchial mainstem, and the other lumen remains in the trachea. It allows access into an isolated lung, suctioning from the isolated lung, and application of continuous positive airway pressure if required to improve oxygenation. Ventilation of either or both lungs can easily be achieved. Procedures that require one lung ventilation include lobectomy, pneumonectomy, pleural decortication, bulectomy, bronchopulmonary lavage, esophogastrectomy, thymectomy, and mediastinal mass resections. A double lumen endotracheal tube should not be placed in the event of a difficult airway, a very small patient, or presence of an airway lesion or tumor. Double lumen tubes are available in different sizes: 35 French, 37 French, 39 French, and 41 French, in both right and left-sided versions. For smaller adults and children, smaller sized tubes are available, including 32 French left-sided and 28 French. No single predictor can tell what size tube should be used. A large tube has less chance of being dislodged or producing significant resistance to gas flow. However, the placement of a larger tube should never be a goal of its own, and the tube should never be advanced against resistance. In a pinch, the following general guidelines can be used. A woman shorter than 160 centimeters should be intubated with a 35 French tube. A woman taller than 160 centimeters should be intubated with a 37 French. A man shorter than 170 centimeters should be intubated with a 39 French. And a man taller than 170 centimeters should be intubated with a 41 French tube. Several methods can be used to insert the double lumen endotracheal tube under direct laryngoscopy, via tube exchanger, or over a fiber optic bronchoscope. During placement, a laryngoscopy is performed. The distal bronchial, or blue, tube is held with the tip directed upward. As it passes through the glottis, the stylet is removed. At this point, the tube is advanced and rotated 90 degrees toward the side to be intubated and advanced until resistance is felt. The depth is usually between 28 and 30 centimeters. At this point, the tracheal, or white, cuff is inflated, breath sounds are auscultated, and end-tidal CO2 is noted on the capnogram. Correct tube placement is confirmed by direct visualization via bronchoscopy. To do this, the flexible bronchoscope is passed down the tracheal lumen. The anesthetist will deflate the tracheal cuff and pull back until the carina is seen. At this point, tracheal cartilaginous rings are anterior and the tracheal membrane is posterior. The tube is advanced until the bronchial or blue tip enters the left main stem. The blue balloon is inflated with 1 to 3 mils of air until the blue cuff is visible in the left main stem. A portion of the blue cuff should be seen seated in the left main stem. After placement, the patient is typically positioned laterally on the operating room table. After positioning, the tube should be checked again to validate that it has not moved. It is usually a good idea for the anesthetist to check the position periodically throughout the surgery. After the tube is placed, its placement should be confirmed. This step is very important because correct placement might be of paramount importance on patient outcome. The correct placement might be partially confirmed already if fiber optic bronchoscope was used during tube placement. There are multiple methods available to confirm placement. Currently, the use of multiple methods for confirmation of correct tube placement is widely considered to be the standard of care. Auscultation and fiber optic examination are used most commonly. Auscultation is a widely available first-line test. After placement of the double lumen endotracheal tube, the tracheal cuff is inflated and ventilation is attempted. The patient should have bilateral breath sounds and end-tidal CO2 should be noted on the capnography. This tells the clinician that the tube is in the airway. Next, the tracheal lumen is opened and clamped. The bronchial cuff is inflated with minimal volume to stop the leak, usually around 2 mils of air. At this point, confirmation of separation of lungs can be done with air bubble leak tests. One-sided breath sound should be heard, only over the desired lung field. Next, with the bronchial cuff up, the tracheal lumen is unclamped and reconnected, and the bronchial lumen is clamped. The ventilation is attempted through the tracheal lumen. If the tube is positioned correctly, breath sound should be heard over contralateral hemithorax. Then the bronchial lumen is unclamped and reconnected and bilateral breath sound should be audible again. This concludes auscultation for correct placement. Auscultation is not always reliable. Smith and others showed that 48% of blindly placed double lumen tubes were malpositioned. Another study by Aliami and others showed that malposition was present in 78% of left-sided double lumen tubes and 83% of right-sided double lumen tubes. Auscultation should always be supplemented with fiber optic evaluation and repeated every time the patient is repositioned. A rigid laryngoscope is an instrument used to examine the larynx and to facilitate intubation of the trachea. The handle either contains batteries to light a bulb on the blade tip or to power a fiber optic bundle that terminates at the tip of the blade. Light from a fiber optic bundle tends to be more direct and less diffuse. Also, laryngoscopes with fiber optic light bundles in their blades can be made to be magnetic resonance imaging compatible. The Macintosh and Miller blades are the most curved and straight designs in the United States. The choice of blade depends on personal preference and patient anatomy. The curved blades are inserted into the vallecula immediately anterior to the epiglottis, which is literally flipped out of the visual axis to expose the laryngeal opening. The Miller blade is inserted past the epiglottis, which is simply lifted out of the way of laryngeal viewing. The McCoy levering laryngoscope has a 25mm hinge blade tip controlled by a spring-loaded lever on the handle of the laryngoscope, which allows elevation of the epiglottis without the use of excessive forces on the pharyngeal tissues. Inserting a tube into the trachea has become a routine part of delivering a general anesthetic. Intubation is not a risk-free procedure, however, and not all patients receiving general anesthesia require it. In general, intubation is indicated for patients who are at risk for aspiration and for those undergoing surgical procedures involving body cavities or the head and neck, or those requiring paralysis for optimal surgical conditions. Regardless of how many years you have been practicing, it is always important to be prepared. Preparation for intubation includes checking equipment and properly positioning the patient. The tube's cuff inflation system can be tested by inflating the cuff using a 10 ml syringe. Maintenance of cuff pressure after detaching the syringe ensures proper cuff and valve function. The connector should be pushed into the tube as far as possible to decrease the likelihood of disconnection. If a stylet is used, it should be inserted into the endotracheal tube, but be able to be removed without pulling the tube out of the trachea. Most often, the stylet is bent to resemble a hockey stick to facilitate intubation of an anterior positioned larynx. The desired blade is locked onto the laryngoscope handle and the bulb or light source is tested. An extra handle, blade, and endotracheal tube one size smaller should be immediately available. A functioning suction unit is needed to clear the airway in case of unsuspected secretions, blood, or emesis. After proper positioning, the blade is inserted into the patient's mouth with careful care to avoid the teeth, and the handle is raised up and away from the patient in a plane perpendicular to the patient's mandible to expose the vocal cords. The endotracheal tube is passed through the abducted vocal cords. The cuff is inflated with the least amount of air necessary to create a seal during positive pressure ventilation to minimize the pressure transmitted to the tracheal mucosa. After intubation, the chest and epigastrium are immediately auscultated and a capnographic tracing is monitored to ensure a tracheal intubation. If there is doubt about whether the tube is in the esophagus or trachea, it is prudent to remove the tube and ventilate the patient with a mask. Otherwise, the tube is taped or tied to secure its position. Although the persistent detection of carbon dioxide by a capnograph is the best confirmation of tracheal placement of a tube, it cannot exclude bronchial intubation. The earliest manifestation of bronchial intubation is an increase in peak inspiratory pressure. A failed intubation should not be followed by repeated attempts that are merely more of the same. Changes must be made to increase the likelihood of success. Change your patient's position. Decrease your tube size. Grab a stylet. Use a different blade. If you try the exact same technique with the same equipment, you're going to have the same view and the same outcome. There is no shame in asking for help if it is available. It's a person's airway that we're talking about. You've gone to the ER to intubate someone that everyone around has taken a stab at, and you know what the back of their throat looks like. Save your coworker the same view and ask for help earlier rather than later. If the patient is also difficult to ventilate with a mask, alternative forms of airway management must be immediately pursued. Nasal intubation is similar to oral intubation, except that the endotracheal tube is advanced through the nose and nasopharynx into the oropharynx before laryngoscopy. The nostril through which the patient breathes most easily is selected in advance and prepared. Phenylephrine nose drops vasoconstrict vessels and shrink mucous membranes. If the patient is awake, local anesthetic drops and nerve blocks can also be utilized. A tracheal tube lubricated with water-soluble jelly is introduced along the floor of the nose below the inferior turbinate at an angle perpendicular to the face. The tube's bevel should be directed laterally away from the turbinates. To ensure that the tube passes along the floor of the nasal cavity, the proximal end of the tube should be pulled cephalad. The tube is gradually advanced until its tip can be visualized in the oropharynx. Laryngoscopy, as discussed, reveals the abducted vocal cords. Often, the distal end of the tube can be advanced into the trachea without difficulty. If difficulty is encountered, passage of the tip of the tube through the vocal cords may be facilitated by manipulation with McGill forceps, being careful not to damage the cuff. Nasal passage of endotracheal tubes, airways, or nasogastric catheters is dangerous in patients with severe midfacial trauma because of the risk of intracranial placement. We are all more comfortable with direct visualization when performing a laryngoscopy, but on certain occasions, a blind intubation is required. This can be done orally or nasally. In a blind nasotracheal intubation, an endotracheal tube is lubricated and deformed for a few minutes in order to exaggerate its curvature. The patient's head should be placed in the sniffing position. After preparation of the nares, the tip of the tube is gently introduced into the nare at a plane perpendicular to the face. Air movement through the tube should be continually felt, heard, or monitored by capnography. The tube is incrementally advanced during inspiration. If the patient's respirations continue but no airflow is detected through the tube, the tip has passed the glottis and is in the esophagus. In that case, the tube must be withdrawn and advanced again. Breath holding and coughing signal close proximity to the larynx, and tube advancement should be continued with each inspiration. If the tube does not easily enter the trachea, several maneuvers may enhance success. Extension of the head will also tend to guide the tube more anteriorly, whereas head rotation will move the tip laterally. Laryngeal or cricoid pressure may beneficially change the relationship between the tip and the glottis. Inflation of the tube cuff into the hypopharynx may also force the tip anteriorly. If the tube persistently slips into the esophagus, voluntary tongue protrusion will inhibit swallowing and may move the tongue and the tube anteriorly. Light wands may be useful for blind intubation into the trachea. When light is well transilluminated through the neck, in a jack-o'-lantern effect, the end of the endotracheal tube is at the entrance of the larynx, and the tube can be threaded off the wand and into the trachea in a blind fashion. Retrograde intubation involves the passage of a catheter through the cricothyroid incision upward so as to protrude through the mouth. It is then possible to use the catheter to railroad an endotracheal tube into the larynx. This technique may be carried out under local or general anesthesia, but it has complications and is not recommended for inexperienced hands. A TUI needle is attached to a saline-filled syringe through a cricothyrotomy puncture. Penetration of the larynx is verified by the aspiration of air. The needle is angled 45 degrees cephalad with the bevel pointed anteriorly. An epidural catheter is passed through the needle until it appears in the mouth. The catheter is anchored at its entry point in the neck. While tension is kept on the catheter, a lubricated endotracheal tube is passed over the catheter and advanced until it passes through the vocal cords, indicated by a click. If there is any obstruction to passage at this point, the tube can be rotated 90 degrees. If this fails, a smaller tube should be tried using the same technique. Possible complications include bleeding, perforation of the posterior wall of the trachea with the needle, subcutaneous emphysema of the neck, a pneumothorax, or infection at the puncture site. It is easiest to appreciate the distinction of rapid sequence intubation if an induction under non-rapid sequence conditions is understood. Ordinarily, the patient has fasted for at least 6 to 8 hours and is not at significant risk for pulmonary aspiration of gastric contents. The patient is pre-oxygenated and an anesthetic induction agent is administered. Once it is established that the patient can be satisfactorily mask ventilated, a muscle relaxant is given. The patient is then mask ventilated until complete paralysis has taken place. Laryngoscopy and endotracheal intubation are undertaken and the case proceeds. In contrast, rapid sequence intubation is undertaken in patients who are thought to be at risk for pulmonary aspiration of gastric contents. Patients with full stomachs are at risk, and other risk factors include pregnancy, diabetes, pain, opioids, recent traumatic injury, intoxication, and pathologic involvement of the GI tract, such as a small bowel obstruction. Patients with full stomachs should be premedicated with agents that reduce the acidity and volume of gastric contents, such as H2 blockers, non-particulate antacids, and gastrokinetics. The goal of rapid sequence intubation is to secure and control the airway rapidly. The patient is pre-oxygenated passively. Cricoid pressure is applied and an induction agent is administered, followed quickly by a rapid-acting muscle relaxant, either Sux or rocuronium. The cricoid pressure or Sellick maneuver prevents the entry of regurgitated gastric contents into the trachea and lungs and is maintained until the airway is secured and confirmed via end-tidal CO2. If the physical examination leaves in question the ability to ventilate and intubate once the patient's anesthetized and paralyzed, consideration should be given to awake intubation. Patients with a previous history of difficult intubation, acute processes that compromise the airway, mandibular fractures, or other significant facial deformities, morbid obesity, or cancer involving the larynx are reasonable candidates for awake intubation. A frank discussion with the patient is necessary because patient safety is a priority. The anticipated difficulty of airway management and the risk of proceeding with anesthesia without previously securing a competent airway should be conveyed in clear terms and documented accordingly. In preparing the patient, administration of Robenal 0.2 to 0.4 milligrams 30 minutes before the procedure is useful to reduce secretions. Nebulized lidocaine may be used to provide topical anesthesia of the entire airway, though many techniques are available to provide airway anesthesia. A transtracheal injection of lidocaine can be performed via needle puncture of the cricothyroid membrane, and nerve blocks are also useful to provide topical anesthesia. Preparation of the operating room is very important. Topical local anesthetics, intravenous sedatives, a selection of oral and nasal airways and endotracheal tubes, suction, a fiber optic endoscope, and other airway adjuncts should be readily available. The anesthetist should formulate a plan for achieving awake intubation and consider a backup plan as well. A surgical airway should be at bedside when loss of airway is a real possibility. Once the patient arrives in the operating room, standard anesthetic monitors are applied and supplemental oxygen is administered. The patient is sedated with the appropriate agents such as opioids, benzos, or low-dose propofol. The level of sedation is titrated so that the patient is not rendered obtunded, apneic, or unable to protect their own airway. As sedation is titrated, the route of intubation may be oral or nasal depending on surgical needs and patient factors. If nasal intubation is planned, the nasopharyngeal mucosa must be anesthetized and vasoconstrictor substances are applied to prevent epistaxis. Often, nasal trumpets with lidocaine ointment are gently inserted to dilate the nasal passage. Once an adequate level of sedation and topical anesthesia is achieved, the endotracheal tube is loaded on the fiber optic scope. The scope is gently inserted into the chosen passage, directed past the epiglottis, through the larynx into the trachea, and used to visualize tracheal rings and the carina. The endotracheal tube is passed into the trachea and the scope is removed. Breath sounds and end-tidal carbon dioxide are confirmed and general anesthesia can begin. This slide describes useful medications and their dosages for awake intubation. Judging when to remove an endotracheal tube is part of the art of what we do. It is an extremely important part of the practice as more complications arise during extubation and immediately afterward than with intubation. In general, extubation is best performed with a patient either deeply anesthetized or awake. Either way, adequate recovery from neuromuscular blocking agents should be established prior to extubation. Extubation during a light phase of anesthesia is avoided because of the increased risk of laryngospasm. The distinction between deep and light anesthesia is usually apparent if there is any reaction to suctioning, like breath holding or coughing. No reaction when the air is let out of the cuff is also characteristic of the patient being deep. Extubating an awake patient is usually associated with coughing around the tube. This reaction increases the heart rate, CBP, arterial blood pressure, intracranial pressure, and intraocular pressures. It may also cause wound dehiscence and bleeding. The presence of a tube in an awake asthmatic patient often triggers bronchospasm. Deep extubation may be preferable in patients who cannot tolerate these effects. On the other hand, such extubation would be contraindicated in a patient at risk for aspiration or whose airway may be difficult to control after removal of the endotracheal tube. Regardless of whether the tube is removed when the patient is deeply anesthetized or awake, the patient's pharynx should be thoroughly suctioned before extubation to decrease the risk of aspiration or laryngospasm. In addition, patients should be ventilated with 100% oxygen in case it becomes difficult to establish an airway after the endotracheal tube is removed. Applying a small degree of positive airway pressure on an anesthesia bag connected to the tube may help blow secretions that have collected on the cuff up and out of the airway into the pharynx. The tube is withdrawn in a single smooth motion and the face mask is usually applied to deliver 100% oxygen until the patient is stable enough for transportation to the recovery room. The complications of laryngoscopy and intubation include hypoxia, hypercarbia, dental and airway trauma, tube malpositioning, physiological responses to airway instrumentation, or tube malfunction. These complications can occur during laryngoscopy and intubation, while the tube is in place, or following extubation. Instrumentation with a metal laryngoscope blade and insertion of an endotracheal tube often traumatize delicate airway tissues. Damage to the glossopharyngeal, hypoglossal, lingual, superior laryngeal, recurrent laryngeal, and branches of the trigeminal nerve have been reported after airway management. Laryngoscopy and intubation can lead to a range of complications from a sore throat to tracheal stenosis. Less serious complications occur more frequently. Dental damage is the most common cause of malpractice claims with an incidence of 1 in 4,500. Serious injuries include subluxation, fracture, and avulsion of teeth. Diseased teeth are at particularly high risk, but healthy teeth can also be injured. Most injuries are due to prolonged external pressure on sensitive airway structures. When these pressures exceed the capillary arteriolar blood pressure, approximately 30 millimeters of mercury, tissue ischemia can lead to a sequence of inflammation, ulceration, granulation, and stenosis. Post-intubation croup caused by glottic, laryngeal, or tracheal edema is particularly serious in children. Vocal cord paralysis from cuff compression or other trauma to the recurrent laryngeal nerve results in hoarseness and increases the risk of aspiration. The incidence of postoperative hoarseness appears to increase with obesity, difficult intubations, and anesthetics of long duration. Smaller tube sizes are associated with fewer complaints of postoperative sore throat. Repeated attempts at laryngoscopy during a difficult intubation may lead to periglottic edema and the inability to ventilate with a face mask, thus turning a bad situation into a life-threatening one. A laryngospasm is a forceful, involuntary spasm of the laryngeal musculature caused by sensory stimulation of the superior laryngeal nerve. Triggering stimuli include pharyngeal secretions or passing an endotracheal tube through the larynx during extubation. Laryngospasm is usually prevented by extubating patients either deeply asleep or fully awake, but it can occur in an awake patient. High-pitched inspiratory stridor is a classic sign, but complete airway obstruction is silent. Mild laryngospasm should be managed initially with positive pressure ventilation by face mask, along with head extension and jaw thrust or administering IV lidocaine, usually at a dose of 1 to 1.5 milligrams per kilogram. The Larson maneuver of inward pressure in the laryngospasm notch between the mandible and mastoid process has no disadvantages and should be attempted. If laryngospasm persists and hypoxia develops, succinylcholine around 0.1 milligram per kilogram should be given to relax the vocal cords and allow controlled ventilation. The large negative intrathoracic pressures generated by a struggling patient during laryngospasm can result in the development of negative pressure pulmonary edema. Negative pressure pulmonary edema is a consequence of forceful inspiratory effort in the presence of a closed glottis or other cause of upper airway obstruction. The subatmospheric alveolar pressure generated promotes transudation of fluid from pulmonary capillaries into the interstitial space and alveoli. Management consists of relief of the obstruction, oxygen therapy, and standard management of pulmonary edema. Most cases resolve rapidly, but reintubation and positive pressure ventilation are sometimes required. An airway assessment should be conducted whenever feasible prior to the initiation of anesthetic care and airway management in all patients. The intent of the airway history is to detect medical, surgical, and anesthetic factors that may indicate the presence of a difficult airway. If possible, patients should be questioned about adverse events related to previous airway management episodes. For instance, have they ever been informed by an anesthetist that they had a difficult airway? Have they had a tracheostomy or other surgery or radiation about the face and neck? Have they sustained significant burns to these areas? Do they have obstructive sleep apnea or TMJ? After interrogating your patient, examine the mouth and oral cavity. Note the extent and symmetry of the mouth opening. 3-finger breaths is optimal. Examine the health of the teeth and document anything loose, chipped, cracked, or missing. A prominent overbite may interfere with the use of a laryngoscope. The size of the tongue should be noted. Large tongues rarely make airway management impossible, only more difficult. Check out the arch of the palate. High arch palates have been associated with difficulty in visualizing the larynx. This slide looks at components of the preoperative airway physical examination that may not be reassuring. A difficult airway is defined as a clinical situation in which a conventionally trained anesthetist experiences difficulty with mask ventilation of the upper airway, difficulty with tracheal intubation, or both. The difficult airway represents a complex interaction between patient factors, the clinical setting, and the skills of the practitioner. The patient who is difficult to ventilate and difficult to intubate is quite possibly the most serious problem faced by anesthetists because hypoxic brain injuries and cardiac arrest are real possibilities in this scenario. Although a thorough history and physical examination are likely to identify the majority of patients with difficult airways, unanticipated problems occasionally present. Only through pre-planning and practice algorithms are such situations managed optimally. This slide is a difficult airway algorithm prepared by the ASA to assist clinicians in these situations. The relative merits of different management options, surgical versus non-surgical, awake versus post-induction intubation, and spontaneous versus assisted ventilation are weighed. Once these decisions have been made, primary and alternative strategies are laid out to assist in stepwise management. This algorithm deserves close and repeated inspection before the anesthetist attempts to manage such problems. This is not a time for heroism. If intubation and ventilation is difficult, call for help. The responsibilities for issues that may influence future safety of the patient does not stop after the case. After a difficult airway, the presence and nature of any airway difficulty should be documented, the patient should be informed, and any complication should be evaluated and managed. Documentation should include a description of the airway difficulties, the management used, and the number and duration of attempts. In some cases, a letter to the patient and their primary care provider should also be considered for future reference. In conclusion, airway management is at the core of care of anesthetized and unconscious patients. Though straightforward much of the time, it can be very difficult. Many new devices and techniques have become available, and their strengths and weaknesses have become apparent. Editorials have emphasized the need for skills and increased range of techniques of tracheal intubation. The range of equipment available, development and maintenance of skills, and organizational factors such as appropriate allocation of personnel are important safety issues. Skills with the combination of the Macintosh laryngoscope, LMA, and introducer are not sufficient core skills to allow safe airway management of all patients. Crosby stated that there is a population of patients for whom exclusive reliance on direct laryngoscopy is a high-risk strategy resulting in morbidity and occasionally mortality. We should emphasize practitioners developing experience and a high comfort level with a limited number of alternatives. We should seek to emulate the safety culture of the airline industry, wherein regular practice is used to train staff to deal with infrequent emergencies. There is no excuse for poorly designed procedures when human life is at risk. Let's review some key concepts covered and applicable to this lecture. In pediatrics, infection-related airway compromise and congenital airway malformations are the major airway management problems. Upper airway endoscopy with a rigid laryngoscope or fiber optic bronchoscope is useful in defining anatomic challenges in patients with upper airway pathology before induction of general anesthesia. If in doubt about the ability to ventilate or intubate, the airway is best secured while the patient is awake and breathing.